nursing students want black and white answers. I can't give you black and white answers. This is going to be different patient to patient depending on what's wrong with the patient. If the patient has respiratory problems, we may do a more in-depth respiratory assessment. If the patient's got abdominal surgery or had abdominal pain, we're going to do a more in-depth abdominal. So those are the pieces that we've been teaching you for the last 8 weeks. You're going to bring out those other questions. I always like to look at the chart before I go into the room so I have an understanding of what's going on with the patient. So when I'm in the room with the patient, I'm matching what the patient is telling me with what I know from the chart. So I'm seeing, is the patient awake, alert, and does their story match what I've just read, okay? I'm used to dealing with patients that are not very mobile. They're in bed, they're in an ICU a lot of times, so they're not likely to jump up. Most of the time you're going to do an assessment, it'll be 7:15, 7:30 in the morning. You're not going to have that patient get up and walk right then and there. So you may do this assessment in like 2 bits. The first bit is a general overview to make sure the patient's safe. And then as you see the patient get up and go to the bathroom or get up and go for a walk, you're going to be adding in that piece of, oh, their gait is really stable, or wow, they're really unstable, or man, I need some more help getting this patient out of bed. So you're going to be adding those pieces in. You may be adding pieces in when you do the bath. Wow, I thought they could do a lot more for themselves. They're really limited. I don't know that they're going to be able to go home. And so you're probably the best person. So we've had nursing students, we have a cone, 10 o'clock in the morning, the care manager, the social worker, the nurse manager, and the nurse get together and they discuss collaborative care. And a lot of times it's a student nurse that says, wait, you're sending my patient home? Do you know he lives by himself? You know he can't feed or bathe himself. I just had to give him a bath and he can't do anything. I don't know that he's safe to go home. And then the social worker or the care manager has said, we need to get occupational therapy to come assess him. We need to get PT to get him walking. Maybe he needs a skilled nursing home stay for 2 weeks. Maybe we need additional resources. So the student nurse has been able to add a lot of details, because remember, those nurses are often having 5 or 6 patients and they're focused in giving medicines. So they don't see that patient not being able to feed himself, or they don't see that patient not being able to get out of bed by themselves, okay? So this is the way I do a head to toe. It may be different than what you're used to. It may be different from what you're going to do, and that's okay. It does not have to be this way. This is just the way I do it, right? So I don't have any pockets. Okay, so I've washed my hands, I've read the chart, I've knocked on the door, I've introduced myself, and I'm walking into the room. And as I walk in the room, I immediately start doing an environmental surveillance. Are the chair rails up, side rails up? How high is the bed? Is there stuff on the floor? Is there stuff like oxygen tubing, IV lines? What's going on with this patient, right? So I'm going to come over here and say, hi, Miss Amy, my name's Sarah. I'm going to be your nurse for the day.
Hi, how are you doing?
So as I walked in, did you see what she did? She tracked and she followed me. So that immediately says she's awake and alert to a degree, and she's following. Now I'm talking to her and she's interacting, so I'm starting my neuro assessment. So tell me, what happened to you?
Well, you know, I just fell.
Okay.
Yeah.
So does her story match the story in the chart? What's her speech like? Is it clear? Is it slurred? Is she got good eye contact? I'm looking at her eyes, I'm looking at the symmetry, so I'm inspecting her, right? Is she able to hold her head up? What's her lethargy level? So, can you tell me where you are right now?
I'm in the hospital.
Okay, and what day is it?
November 25th, 1942.
Okay, so if she was that confused, I would do more Perla, okay? If she was awake and alert, I
I
wouldn't.
fell and hit my head. So.
Yeah, but if she's awake and alert, I wouldn't do Perla. If she is confused, I would do Perla. So this is where you bring in or bring out different pieces of the assessment, okay? I might do the Glasgow Coma Scale. If I'm on 1C, I might do the NIH Stroke Scale. And we'll show you that in more detail if you go to that floor. So I'm talking to her, I'm checking her wristband. Remember, I've washed my hands, right? So as I'm checking her wristband, I'm holding a hand. I'm checking her radial pulses. So I'm gonna come over here, I'm gonna check her other radial pulses, so I'm checking her perfusion. I'm gonna check the color and sensation of her hands. I'm gonna come down here, I'm gonna check her, what's this called?
Cavity.
Cavity feel.
I'm gonna ask her to squeeze my hands real tight. So number one, can she hear me? Number two, can she follow commands? I'm gonna ask her to flex her hands up above her head. I'm gonna ask her to press down towards the floor. So what am I checking now? Neuro and musculoskeletal strength. I'm gonna check her arms. I'm looking for any IV sites. If she has any IV sites, I'm gonna check. Is it clear? Do I have any drainage? Is it warm? Is it cool to touch? What does the IV line look like? And does the IV line match the report that I was given? So I'm coming up her arms now. I'm looking for symmetry. I'm looking for color. Okay? I'm now going to start off at the head. I'm going to look at her eyes. Do her eyes look normal? Are they round? If I had to do Pula, I would do Pula here. Okay? I would ask her, we have to stick your mask off a minute. When you see HENT, a lot of hospitals now are really focused on mouth care. There's been lots of studies that say that poor mouth care leads to health-associated pneumonias. So we want patients to be able to stick their tongue out. Okay, look at the color of the tongue, look at the moisture. It should be pink, it should be moist. Ask them to wiggle it side to side and smile, because we're also looking at teeth. If they have lots of rotten teeth, that's often an indication of lots of bacteria in the mouth. We need to do more mouth care so they don't get health-associated pneumonias. So when you do EPIC, that's the first tab that you're going to start looking at, is that mouth care. Okay?
Sorry, did you say CHENT?
HENT.
Okay.
Yep. So now I'm looking at the neck, I'm looking at the carotids, I'm looking at the jugular vein, what we call jugular vein distension. Remember we talked about that congestion of the heart? Okay? If you have carotid pulsations, you'd look and see. 99% of the time you're not going to see them, so if you see them, you're like, whoo, right? I'm going to be looking at her chest and neck. I'm going to be saying, Miss Amy, I need to do an exam on you. I'm going to raise your gown up so I can look and feel and listen to your chest. Are you okay with that? So I'm going to raise the gown up, so cover the sheets up, right? So it's here. Raise the gown up. What did we just say the order was? Inspection. I'm looking at her chest. I'm looking at the skin. I'm looking at the color. I'm looking to see if there's any retractions. I'm looking to see that the chest wall is rising symmetrically. If not, I'm going to check that excursion we talked about before. I'm looking to see if there's any scars. So if she has a big scar, I might say, oh, well, tell me what this is about. I don't remember reading that, like what's going on here, right? I'm going to look at, are there any heaves or pulsations? Remember what heaves and pulsations were, like ripples under the skin? That could be like mitral valve regurgitation, okay? So I'm inspecting the chest for respiratory and cardiac problems at the same time, okay? Once I've inspected, I'm gonna say, does anything hurt here? So that's my palpation. Then I'm gonna put in my ears and I'm gonna listen. Now, depending on your patient, depends on how many times you might listen. For most people, 6 times on the front is probably fine. Upper lobes, middle lobes, lower lobes. When I listen to the lower lobes, I tend to listen more laterally, because remember your lung tissue goes down and dirt and debris fall in. If I have a lung patient, I may listen 8 times or 10, so I can decide how much depending on what I'm hearing and how sick my patient is. But I'm looking for that work of breathing. I'm looking for that sentence structure, right? So I'm gonna listen for upper lobes, middle lobes, lower lobes. Since I've got my ears in, now I've done my respiratory assessment, I've already inspected and palpated the chest. I'm gonna go straight to my cardiac. I'm gonna listen with my stethoscope for my heart sounds. Is it regular? Is it irregular? Is it normal sinus? Is it slow? Is it fast? I've already checked her peripherals. I'm gonna check her feet in just a minute, okay? So that's my cardiac. Now I've got a gown raised, I've got my stethoscope in, so to me, the next logical step is I'm gonna look at her belly. She probably needs to slide out a bit flatter, but. So I'm inspecting the belly. I'm looking for the concave or convex part of the belly. I'm looking for any scars, I'm looking for any pulsations, I'm looking for any surgical sites. So are they dry, are they clean, are they intact? As I'm checking the belly, I'll often say to her, tell me about your bowel movements, tell me about your eating habits, are you eating, are you nauseated, do you have any pain? So I'm asking her about her pain level, and once I've inspected the belly, what's the next step for the belly? Auscultate. So the way I auscultate is, hang on, she's miserable without a pillow. You wanna-
I just
you okay?
don't wanna have to clean it.
I understand. So I'm gonna start here in my right lower quadrant, go up here to my upper. Remember, you may have to listen for 3, 4, 5 minutes sometimes, especially for those post-surgical patients because their gut's really sluggish. You're gonna come over here to your left upper and then the left lower. Why that order? That's the way the bowel moves, right? So once I've inspected, I've now auscultated, now I'm gonna palpate. And that's why I wanna know what sort of surgery the patient's had, what sort of issues, so I know where it's likely to be tender, so I know how hard or soft to be pressing, right? So now I've done the belly, I'm gonna lower the gown down, I'm gonna look at the GU. Does she have a Foley? How are you peeing? How are you getting up? How are you voiding? Right, because I'm working my way down the body. So now I'm gonna come down here and I'm gonna raise my legs, feel down the back. What am I feeling down the back for? Warmth, redness, swelling. So I'm checking for phlebitis, I'm checking for a deep vein thrombosis. I'm gonna feel her heels. What am I looking for in the heels? Are they boggy? Because a lot of people will have skin breakdown at their heels, right? They have pressure injuries. You can keep dragging them up and down the bed, right? I'm gonna come down here, I'm gonna check her pulses in her feet. So this is what sort of pulse? Pedal. She has bounding pulses. I can feel them through her socks. I'm going to, if she has TED hose or SCDs, I'm gonna take all of that off because I wanna look at her skin. I'm gonna check her cap refill of her toes and her feet. So now I've done the heart, I've done the radial, and I've done the dorsalis pedal pulses, so I'm really checking her perfusion. I'm looking at the color, I'm looking at the sensation, I'm looking at the temperature of her feet. I'm gonna be pressing in her ankles. Why am I pressing in her ankles? I'm looking for any edema. So now I've done that, I'm gonna ask you to put your toes over your head for me. Perfect, and I'm gonna stop you, and I'm breaking a calf. So now I'm checking her muscle strength, of flexion and extension. So now, and again, this is just the way I do it, I come around this side of the bed, because then I've seen like a 360 degree. I'm gonna ask her to roll over for me. So, can you roll over for me? The other way. Would help if you had a cooperative patient, right? So I'm going to be opening her gown up, I'm gonna be inspecting her back. I'm gonna be looking at her skin. Is there any redness, especially down the spine? Little old people often have skin soreness down there because they're thin. I'm going to be feeling, is there any crepitus? Is there anything going on I don't know about? And then I'm gonna be auscultating. And again, I'm gonna be auscultating in those 3 lobes, upper, middle, lower. I'm gonna look at her bottom, especially her butt. Cone loves, I don't know what the product name is, but it's just pink foam.
The Mephilex. Is it the Cure?
What is it?
The Mephilex, the little butt pad? that
Yes,
pushes
the
hard?
one that's like this big.
Oh my gosh,
Yes.
UNC loves that too.
So everybody has that, you have to look underneath that. You can't say, oh yeah, they've got it on. You have to look at the skin underneath it, and it should be dated, and you remove it every 3 days per Cone's policy. So you have to look at that, you have to look at the skin, and you have to know the date, because you're gonna have to chart this in just a while. So, once I've finished, I'm gonna roll her back. I'm gonna put her in the 4 Ps. Are you familiar with that expression? Okay, I'm gonna ask her, does she need to go to potty? Does she have her personal belongings? Does she have any pain I need to do something about? And what's the fourth one?
Position, am I
Position.
in a comfortable
Is she in
position?
a comfortable position? And then, because I raised the bed, because I don't like to bend over, I'm gonna lower the bed back down before I leave. Okay? So again, that's the way I do it. You can choose to do it a different format than me, but at the end of the day, you've gotta be able to get everything done. Okay? Yes,
So, like, if they had, like, say, a neurological issue, you would go more in depth with, like, the cranial nerves and stuff?
Yes.
Okay.
so you would then go through that cranial nerve, you would go through the Glasgow Coma Scale. If they had abdominal surgery and they had a colostomy, you go more in depth of what colors that colostomy, what's coming out of that colostomy. If they've got a drain, what's coming out of that drain, how much is coming out of that drain. And if you have a patient that says, has an IV line at 75 an hour, you're gonna check, yes, I've got lactated ringers at 75 an hour. So you want to check that at the beginning of your shift, because you don't want to find out at 4 o'clock in the afternoon when the nurse says to you, have you emptied your Foley? That patient hasn't peed all day. And you go in and you find instead of 75 mils an hour, it's running at 7.5. And you're like, when did that happen?
Oops.
And it's like, okay, whose error is that now? So if you find something at 4 o'clock in the afternoon, whose fault is that? If you find it at 7:15 in the morning, whose fault is it? It's the night nurses. So you always want to check when they say the IV's running at and it's X fluid, and you say, wait, hang on, you said LO and you got D5 hanging. Oh crap, I forgot. I called the doctor and he changed the order. Let me go put that order in. Okay, I mean, that's fine, that happens, but I want you to put all the orders in you need to put in before you leave. So the nurse may tell you, hey, the IV's running at 10, you come in the room and it's running at 100. And you're like, wait, what just happened? And if that nurse goes home, and a lot of night nurses work nights so they can go home, take the kids to school, and then go to bed. And you can be phoning that nurse and they're not answering the phone. And you're like, well, it's supposed to be 10 or is it supposed to be 100? And you call the doctor, and guess what? The doctors have changed shifts. And he's like, well, how the hell do I know? I've been here for 10 minutes. What did you get in nursing report? Well, I got 10, but it's running at 100, and I really don't know what the plan is here. So then you have problems to begin your shift. So you want to check your oxygen, you want to check your IV lines, you want to check any drains while that night nurse is still there, and that's why you do bedside rounding, so you are in agreement, because sometimes we've had horror stories of, oh yeah, the patient's fine, he's just sleeping, and the nurse is like, well, I'll come back later, I'll come back later. The nurse comes back at 10 o'clock, and she can't wake the patient up. And it's like, well, was he sleeping this morning or was he unresponsive this morning? Big difference, right? So then it's, well, why didn't you see him at 7:15 while I was busy and I thought he was just sleeping? Yeah, that's not acceptable. So partly success is going to be how you communicate, and if you are very timid and say, is it okay if I do an assessment? Some patient's gonna say, oh honey, I'm eating breakfast. Okay, can I come to an assessment now? Oh honey, I'm going down to PT. And the nursing instructor's like, have you done your assessment yet? It's 2 o'clock in the afternoon. Well, yeah, my patient's been busy. Well, yes, patients are busy in the hospital. You need to get that assessment in by 8 o'clock. Because if you don't get it in, if something happens, if they come to you at 11 o'clock and say, hey, Uncle Joe isn't acting right, and you haven't seen him, you don't know where he was, and when you call the doctor and the doctor says, well, what was he like when you saw him this morning? Well, I don't know, I didn't see him. What do you mean you didn't see him? This is your patient, this is your responsibility. So even if you don't get a complete assessment, you need to get the neuro, you need to get the cardiac, you need to get the respiratory and the abdominal. You may leave the skin till later, you may leave the gait till later, but you gotta get, is the patient stable or unstable? And I've had times when they're like, well, come and take him for dialysis. I'm like, no, you're not. I'm gonna go in there and I'm gonna spend 5 minutes with this patient before you leave, because if you suddenly call me and say, hey, we have a crisis, I need to know what's going on with this patient before you take him off the unit. Because that nurse is legally responsible for that patient. So sometimes I'm like, yeah, you can wait 5 minutes. I'm going in there before you are. I'm gonna get a set of vital signs. I'm gonna listen to him. I'm gonna look at him before you take him. And it may not make me the most popular person in the world, but at the end of the day, this is my patient. Right? So any questions about head to toe assessments?
So we will only have one patient
Correct.
for each clinical day?
Yes.
Okay.
This semester.
Okay.
As the semesters go on, as
Get
you get
more.
more comfortable, then maybe next semester you'll have 2. Maybe the next semester, next fall, you'll have 3. So by the time you graduate, you'll have 3 to 4. So it's not a culture shock of, what do you mean I'm the RN and I have 5 patients a day? You're like, woo, how did that happen?
Okay.
You'll be in that groove. But I promise you, the first day, it's pretty common for us to be doing charting till like 2 o'clock in the afternoon.
Oh, yeah.
Because people are clicking every box and they don't know where to go, and by the second day, they're charting by 11 or 12, and by the third day, they've seen their patient, they've done their assessment, and they charted by 9 o'clock, and you're like, whoo! Because now we can go do other stuff. Now we can go to x-ray, and we can go to MRI, and we can go to dialysis, and we can see what the patient is experiencing.
So you don't chart as you go. You do your whole head to toe, what you're gonna do, and do you like write your vitals on like your scrap paper or?
Depends
how do
on where you're working.
Okay.
So if you work in ICUs, it does it for you automatically, and you just say, yeah, these are the vital signs I want. And
Okay.
you can chart, you can do vital signs every 2 minutes if you want to.